Hi, Dr. Padera. It's Tyler Parker from your MFT6105 class, Couples and Sex Therapy. And this is my presentation for week number 8. I'm going to cover all the different models of sex therapy and also cover the case vignettes that were presented at the end. So, well, here we go. So, if I can get it to, okay, that's definitely not starting out great. There we go. All right. So differences in sex therapy models. Each model therapist and clinicians of many stripes use requires a differing and sometimes contradictory set of etiological assumptions in conceptualizing interpsychic or intrapsychic dysfunction. What I was most struck by with especially the medical model versus the psychological models of sexual dysfunction was that in the medical model, there is a very measured way of looking at sexual dysfunction. Like, for example, if a client has cardiovascular issues and erectile dysfunction, then those would be seen to be correlated with one another. Or, any of the other sorts of different types of, especially male sexual dysfunction, as what was discussed in the article. But, just the fact that in the medical model, they don't really necessarily ask how a person is doing or living or feeling with their problem is a huge departure from the psychological model. Those two, I guess, that would be the one thing that they don't have in common the most between the two of them. Even in the article specifically, as it talks about psychological intervention, it didn't really respect that form of treatment so much, and for some reason the authors kept talking about the cost of that treatment and that would be a deterrent for someone to want to use that. But I just thought that was a little bit odd, but you could definitely tell how the psychological community and the medical community are still at odds with one another, even though they're both trying to solve the same problems because they use different lenses. It's very hard for them to, I guess, trust each other. And there's a lot of that, so I'll get into that. But yeah, each of the different models, even within the psychological etiology, were quite different from one another. So, of course, the medical versus psychological etiology. The largest variances lie in whether sexual and sex-related dysfunction can be conceptualized within a medical context or a psychological one. Few theoretical orientations use an integrated approach, though the integrative model provides an initial framework for such an orientation. So what I really noticed was that the psychotherapeutic approaches, the different theories and theoretical orientations, they didn't really inquire so much into what would medically be causing some of the dysfunction, even though that would be extremely helpful to know and to understand and to be able to work with, especially when you're looking from the medical perspective. If someone is taking a pharmaceutical of some sort or even a psychopharmaceutical of some sort prescribed by a psychiatrist, that could be contributing to why a person has low sex desire or is having erectile dysfunction or any of those other types of disorders or dysfunctions. Just because, they're, with the introduction of those chemicals, their body is responding to that. And, whatever they decide as far as reasons why they're feeling the way that they're feeling, if they have a medical reason why this would be happening, it really doesn't matter what you say, their body's going to respond. So that's something that the integrated approach really touched on a lot, especially in the concluding paragraphs. Talking about that is something that really needs to change, because you have so many different ways to think about how dysfunction comes around. You should take all of those things into consideration in order to provide the best care. You don't have to break new ground, a new territory, with a whole different new theory. You can use all the theories and ideas that we already have and integrate them responsibly to, figure out what's going on. So, yeah, that's that. And then Dr. David Snark with Passionate Marriage, that book, Really great book, by the way. Sex therapy model focuses on partners reaching out to each other from a position of self-love and self-acceptance, braving the insecurities of expressing their sexual authenticity. Um, so that book, what to me it seemed very individual, like an individual psychotherapy approach, even though it was technically couples therapy, and he is trained as a family therapist or couples therapist. um, I thought what was really primary from what he was saying was that a person needs to basically love themselves before they can love someone else. So that's kind of what I got from what he was saying, how problems arise. But one thing that I didn't necessarily understand or agree with um, was the way in which he conceived a dysfunction and presented his hypotheses to his clients. Even in his writing, of course, he's the one who wrote it, so he's able to present it any way that he'd like. But even when he was talking about the responses of the clients to the things he was saying, they were really confused, because of course they were kind of strange conceptions, and they used a lot of like negative phrases. Not negative isn't like bad, but like don't, can't, those things that the mind has a tough time conceiving of. And it was just kind of confusing. And I don't think that as a clinician for myself, I can tell clients what they think better than they can tell me what they think about something. So although I appreciated the way that he had conceived of those dysfunctions, I don't think that I would do it the same way. I think that people do need to love themselves if they're going to want to love someone else, and also to understand the pinnacles, the plateaus. Or I don't want to say plateaus, but the pinnacles that they can reach in their sexual relationship, are things that should be discussed. Like, hey, this is what you can have, but at the same time, like, if you have to provide someone a whole new way to see their entire everything, I think that that's just very hard. I think that it's hard for people to basically stop thinking whatever they're thinking to buy into this new manner of thinking that you've presented to them. So that's the only thing that I think I didn't necessarily think was too useful for me. As I've said before, I really like the narrative therapy approach, because you can collaboratively build the understanding of the relationship as opposed to provide a perspective for the client. So narrative therapy approach, this is going to sound kind of contradictory, but uses the standard process of narrative techniques to restore the couple's dysfunctional sexual life. Similar to the Heart of David Snark's approach, and that therapy is psychologically and more specifically cognitively oriented, not reliant on a medical approach. So I understand that he restores or helps to restore couples' dysfunctions, but he doesn't do it with them. He does it from a one-up approach rather than either a one-down or a side-by-side approach. So I think that although he is brilliant, I mean you know that, I know that, I think that the world knows that. But as a clinician, I don't think with the education that I've gotten so far here that I could responsibly take the one-up approach and sort of like drag people along whatever perspective that I have to provide for them. But narrative therapy, as we've discussed and talked about a lot before, is basically to thicken the narrative of what clients have, so that they have a bigger story to relate their problems to and around, in their lived experiences, so that those problems don't have as much pull as they used to anymore. The more that a person understands about their own experience and the broader their experience becomes, the problems sort of just diminish just by the sheer volume and of information that's provided to them and that they create about themselves and about their relationship. So, you know, doing that, it kind of helps people to see themselves outside of their sexual dysfunction, is just one part of their entire relationship, rather than, you know, encompassing the whole of their relationship, which is, I guess, the problem for some people, not for everyone, but for a lot of people, especially when they present to sex therapy. They're doing it because, you know, it's become such a huge deal for them. So, yeah, that's that. Relational sex therapy. A truly systemic approach to the direct line of descendants from traditional MFT models, sexual dysfunction is seen to be a relational problem whose expression is behavioral in the realm of sex. So I thought that that was a pretty, like I said, a pretty direct descendant from standard marriage and family therapy models, and that it was saying that the relationship itself is what is the problem, but the problem is manifesting itself within the behavior, the sexual relationship between the two people of the couple. So it's not first that there's a sexual problem and then there's relationship problems. It's that there is a relationship problem and it's manifesting in the sexual problems, and then, you know, of course, you have that feedback loop of those problems just basically playing off of each other. It starts hard to understand what's cause and effect, but, you know, from that specific model's approach, it would be that the relationship problem is the cause and the effects would be, you know, the sexual dysfunction. Gender dysphoria perhaps should be considered or inquired about during clinical intake. Psychosocial and somatic in nature, will very likely as a clinical issue lead to a multitude of sexual problems within the relationship. So it's not just gender dysphoria that can be an issue. It's any of the other, and I'll go over this later in one of the later slides, but any sort of mental health issue should be considered in therapy. Gender dysphoria, I guess, especially because if a person, you know, never really agreed with being the assigned sex that they are, and their experience sex is much different than that, then how can they possibly experience sexual freedom or sexual happiness if they're really not the gender that they've been assigned and that they've had to live with? I mean, it's pretty straightforward, but I think that, you know, it's something that you can definitely inquire about, that's sort of off the beaten path, kind of like inquiring about domestic violence or drug abuse in a clinical intake, just because I think that it'll probably save a lot of time. Even though the prevalence really isn't that high, it's something that, you know, I think that if you ask the question to the right person, you'd probably save a lot of time. And you might be the first person to just validate, like, hey, this is an actual thing. Are you experiencing this thing? And I think that society just doesn't do that enough. So kind of is like, I don't want to say like as a political statement, because it's more of like a therapeutic inquiry. But I think that it's something that should be inquired about. Summary of recommendation on sexual dysfunctions in men. Depending on the particular sexual issue, treatment recommendations range from orally administered pharmaceuticals to psychotherapy to surgical procedures, depending on the type and severity of issue. So this is kind of like in other classes where, you know, I did GAD, for example, and they have treatment recommendations for GAD. They have psychopharmaceutical interventions and the different dosages you should give. If you do psychotherapy, what's the most effective psychotherapeutic technique, so on and so forth. So this is pretty much the same, except it's taking it from the medical approach. It doesn't talk specifically about even types of psychotherapeutic intervention. It just says psychosocial treatment, and it's expensive, and so a lot of people don't want it. So, but, you know, it is definitely important to understand what other medical complications a client is going through. because if, it's been an ongoing medical issue, or, they're taking medication for this, or so on and so forth, it's important to know that so that you can take that into consideration when you're deciding what kind of treatment you should give to the client. And I'll go over a little bit later too about, if something is contraindicated, like say for example, a person has had trauma to their pelvis, or a lower back issue that's causing nerve damage going to their genitals, and so it would be actually impossible for them to experience orgasm, something like that. Then telling the person, if you just calm down when you're having sex, you'll have an orgasm, is probably contraindicated, because that's just medically not going to happen. Where on the other hand, if someone doesn't have a medical reason why something is happening, to tell them, if you just calm down, maybe you'll have an orgasm, and then they end up having one, you provide the same treatment, but you're very likely to get one outcome expected vice another outcome, because of another intersecting issue. So understanding those intersecting issues is really important, because it'll keep you on the right treatment path and treatment plan. Incompatibility of the medical and psychological models of therapy. The medical model derives clinical information less from patient reporting of the subjective experience of the disorder, and rather draws information from testable, treatable, and observable clinical indications. The psychological model of sexual dysfunction treatment rely almost exclusively on the subjective report of the experience of the sexual dysfunction, and rely on client work and investment and treatment resolution. All right, so this was really enlightening for me, to think about the incompatibility, because when you think about the life of the client, there aren't clear delineations between the problem and the person's life. So say for example, a person wakes up in the morning and they have some sort of like erectile issues or whatever. And if you're a medical professional, then as a urologist, that's where your specialty kicks in. That's where your interest kicks in. And as soon as that does not become the central issue of the person's living experience at that time, like say, for example, they sit down and they're eating with their wife or their kids at breakfast, as soon as that's no longer central to the thinking or the life of the client, then the urologist doesn't care. As soon as, whatever other issue comes up, whenever that interest is gone, it's like it doesn't matter anymore. So I think that kind of taking the very small slices of a person's life from the medical model where something does matter and you do care, is really missing how that actually affects the person's lived experience. Because the person's life is what is central. Whether it's a medical issue or not, the person doesn't stop being alive, and so you shouldn't stop being interested just because that particular thing isn't occurring at one point or another. And so I think that mental health clinicians are very uniquely positioned to be able to do something about that, because we care about the whole person's life. We care about the moment they wake up until the moment they go to sleep. Oh, and by the way, we also sometimes care about what they dream about. So, it's really, you're monitoring the person over 24 hours of the day, 365 days of the year. It's not just, oh, my back hurts right now, let me go see a medical professional. Oh, my back's not hurting, so why would I even be thinking about that? Well, no, how does your back hurting affect your lived experience and what you think you are capable of doing and what you think you're not capable of doing, so on and so forth. So I just think that they are incompatible in the sense that the medical model is very sophisticated, but it's very limited in the scope of time in which they care about how that disorder or problem affects a person, if that makes sense. But of course, I'm not a medical professional. Maybe they do care, but that's just the impression that I get. Brief solution-focused treatment of couple sexual dysfunction. Using the standard approaches of the BSFT, to help couples find what solutions work in overcoming their problems related to sexual functioning. Little reliance on medical or even psychological etiology of the dysfunction, completely based on what is pragmatic and client-derived. So it's just like the standard brief solution focused therapy technique. You ask a series of questions with scaling or the miracle question, and even I think it's pre-session improvement. You use all those different tricks of the trade to try and basically get down to what's working. Okay, do more of that. What's not working? Okay, don't do that anymore. Complimenting and encouraging and focusing on client strengths and all those things, but you just apply it to the realm of sex therapy. And I think that's good. And even though the integrative approach paper that we read, it didn't talk a lot about the brief solution focused therapy approach, I don't think. But regardless of theoretical orientation, I think that those techniques are really helpful and they're really good, especially because they're empirically validated and there's a lot of research backing up that they work, and they don't really require that you even understand what's going on psychologically or even understand what's going on medically, because you're using the client strengths and you're just kind of like pushing them along the trajectory that they can find themselves on, or will find themselves on with enough encouragement. So that one's still pretty standard to the way that it's typically accomplished. Integration model of sex therapy, a new and future-focused therapeutic framework that seeks to establish the beginnings of the underlying concepts necessary in the creation of a theory of sex therapy that utilizes all the current empirically validated methods of providing sex therapy in a multitude of settings and treatment contexts. I really like this idea because it does call for a mental health clinician, to use all the available evidence to make the best clinical decision of what kind of treatment to take. So rather than some of the other approaches that kind of assume in their presentation that you might work with a medical professional, but it's really not necessary, the integration model really calls for, to collaborate with someone who has a piece of the puzzle. There's even the jigsaw analogy used in the article. So if you understand that something is true, or you understand that something works, or you understand that something is a problem, is an issue, is something that needs to be addressed, you should probably do that, and not just ignore it for the sake of being having integrity with the model that you're treating from, because at the end of the day, that's not what's most important. What's most important is to use all the available evidence and the clues that you have to be able to make the best treatment decision for the client, and that's basically just the bottom line. There's not much more than that, but I think that, as it says in the paper, it's just a framework. It's not a theory, but it is what you should probably know or want to be thinking about for your own practice. So I thought that was really good to hear, and good to know, especially like the concluding 4 paragraphs with the bullets next to them, because a lot of those things are things that I had been thinking about myself anyways, about medical etiology and psychological etiology, and really thinking about which one is the true cause of the problem, rather than assuming that it is whatever your favorite or most, whatever approach you're most interested in is the one that's actually causing the problem. Because that really does a disservice to the client when you choose to think from your own mind rather than inquiring what's going on inside their whole lived experience, mind, body, and spirit. Integrative and narrative approaches. The integrative approach provides the clarity necessary to conceive of an etiology of a couple's sexual dysfunction in a clinically relevant and client-centric way. Narrative therapy provides a psychotherapeutic treatment that is flexible enough to encompass and discuss all the truths relevant for the couple's healing. So obviously, my favorite approach would be the narrative approach, and the integrative model is my new favorite framework. So I think that they work very well together, in that the integrative approach allows for a broader and bigger story. Just in that framework, you have the tools to thicken the narrative already. So half the work is already done for you. So instead of just assuming that all the problem is coming from the story that needs to be restored and the problem needs to come out, so that it can be, seen as an invader, an intruder, or whatever, you can use all the available information that a person has in their case histories from primary care physicians or from medical specialists, and that becomes part of the narrative. That becomes part of the story that's discussed. And what is the relationship between a couple and this story, because it's a part of their whole experience. So it's not just, you don't just use it for, okay, well, after you leave the doctor's office, then let's turn off that and let's focus on the relationship. No, it's how are you living your life in relation to this information, in relation to this story that you have crafted around such and such medical issue, like prostate cancer, for example, as was discussed in the article. So those are the two approaches that I would really use for the case studies that were presented. So this is one of the two, Carol and Michael. So they're separated. They have 4 kids. 2 of them live at home. Carol's having an affair with Dan, who's 42 years old. Carol feels justified in looking outside of the marriage for love. Michael has a higher desire for sex. Carol has a lower desire for sex. So I didn't say that he has a high and she has a low, because it's all relative to one another, I think. So Carol's desire has decreased over the past 20 years. Last few years, intercourse only occurred a handful of times. Carol's surprised at Michael's level of distress. She thought he stopped loving her years ago. Michael said he's always had positive feelings towards Carol, but her lack of interest in sex is equated with not caring about him or the relationship. So from the integrative approach, I would definitely inquire about falling levels of hormones, and it's not to say that that's what the problem is, but again, it's just a searching for clues. So he could he could go to his primary care physician. He could inquire about low T, or see if Carol's having some sort of issues too, and just inquire about that. And if it comes back that the test is negative for any sort of abnormalities, then you know that you don't need to look at that. But I know that couples usually have, if they have problems, one has a lower desire than the other one, and the one with the lower desire is the one that controls the frequency of sex, and that Carol running away from the relationship and in the arms of another person, obviously she doesn't see that that's a bad thing, because she doesn't think that Michael loves her anymore. But it looks like their relationship has more problems than that. I think that it says that they're both really busy people, right? And so not to get into capitalism or anything like that, but basically the way that the capitalist structure work is life gets increasingly more difficult with time as you get promoted in the workforce and you have more responsibility and more time away from home. So that's probably been an issue over the past 20 years, as they've both been working adults and trying to raise kids at the same time, and especially without a routine for reconnection, there's very likely to be sexual distress in their relationship. It probably just manifested when it hit a breaking point at some point, where they were just like, we just don't have enough energy for this, and they both recognize that. But having a relationship where sex is primarily the way that you feel connected to your partner, if there was some sort of accident, or for some reason you couldn't have sex anymore, and you couldn't express that with your partner, and you don't have a backup methodology, that's probably going to be an issue. And so, if Carol sees that, it actually kind of makes sense too that she would try and find someone who's younger, because she's like, hey, if he's younger, maybe he might have a higher sex drive, because Michael's 56 and Dan is 42. That's a 14-year difference between the two. So, to me, approaching this, I would inquire about that. I would say, what other ways do you guys connect with each other? Because it says, Michael's always had positive feeling towards Carol, and Carol obviously was thinking that there was something to salvage in the marriage. Helping them dig out what that is and what his positive feelings really are in the relationship, I think is pretty crucial, pretty critical to maybe saving that relationship, if that's what they want to do. And it sounds like that's what they want to do. So Nadia and Ivan. Nadia does not like sex. She feels numb when it happens. Ivan has become very frustrated with their lack of desire. Nadia agrees with Ivan about the low frequency of sex. Nadia says she can live without it, so she feels bad for Ivan. Ivan threatened divorce if she does not get her problem solved. Medical exam revealed no abnormalities in Nadia by the gynecologist. So, I mean, depending on the kind of workup that the gynecologist ran, if she was just focusing exclusively on her genitalia, then she might have missed, any other sort of medical issue. But, I don't know that. But what I would be most concerned about looking at is any sort of like other mental health issue that Nadia might have, like depression, for example, or dysphoria, or not dysphoria. I can't think of it right now. I think it starts with a D. It's kind of like depression, but it's like less severe. I can't think of what it is right now. But anyways, I would definitely screen her for some sort of like mental health issue aside from that, because she just seems kind of disengaged. Maybe she's even like asexual. I don't know, but in this instance, I would definitely use the integrative models framework for screening for other sorts of mental health issues. Because if you just use like a narrative therapy approach, or like, even a brief strategic approach, or a brief solution focused approach, some stuff might not get through because there is a medical / neurological / neurochemical reason why she's feeling like she just doesn't care, and she feels bad for him, even though it's her body. There's too many red flags there that would tell me that, she might be depressed, or she might, this same mentality might be carrying over into other areas of her life and not just about sex. So I would definitely ask about that. I would even ask about gender dysphoria, as a matter of fact, because, maybe she really doesn't want to be a woman. I don't know. But I think that it's important to inquire. So, before any other sort of narrative therapy can be done, I think that a bigger picture needs to be painted about Nadia and Ivan, and especially, screening Ivan for like narcissistic personality disorder, or like something that, he sounds like from the story that he might be a little bit on the aggressive side. So I would want to, see the bigger picture, see if part of their story is that he's aggressive in other areas, or he's aggressive at different times, inappropriate times and things like that, or even domestic violence, to be honest. I think that's important to understand. So that is pretty much how I would start off with that case. So the utility of here it is. The utility of screening for medical and mental illnesses. Approaching sex therapy with a couple is already a complicated enough project, but without a clear picture of the psychological landscape of a couple's individual mental health issues, treatment can be further complicated. These issues can be even further complicated without a clear medical history that can make psychotherapeutic treatment either contraindicated or minimally effective, given any other concurrent treatments with a physician or other medical service provider. So I already touched on that, but at the same time, what I forgot to mention was that it seems like, and it's been stated in the reading, that Sex therapy approaches are really siloed, and they're really small silos, and there's not a lot of integration when it comes to, theoretical orientation or, treatment plans. They're all kind of just doing their own separate thing, and they're all just focused on sex. And the sex therapy doesn't traditionally, I guess, branch out into other areas of a couple's life, which it should, because sex isn't just its own thing, it's just a very powerful thing. But it's a very powerful thing in a whole of a person's lived experience. So, even it says that this is pretty much all the sex therapy education that we're going to get. I guess at this school, I don't know, but considering that sex and dreams are probably the biggest slices of a person's emotional life, I think that it's probably pretty important to be well versed on what it is, what can be done, and understanding of it, more than just a week or whatever it is. But anyways, yeah, that's what I think about that. So those are my references. I pretty much used everything. So, yeah, I'm pretty sure that that's 20 minutes. It's probably longer than that. But yeah, that's, I think that I covered what the information that you wanted. And if there was something else that you wanted that I neglected to mention, please let me know so that I can provide an answer for whatever that is. Okay, well, yeah, thank you for your time. I'm sorry it's probably long.